Good morning. My name is Attila Kaplanzi and I'm the sales director for Lumitera. First of all, I would like to thank the organizers for letting me hold a lecture here. I regret that I cannot be present personally. I have already booked my flight, but my flight got canceled due to bad weather in Munich. So we are lucky because of the high technology who can enable me to be here virtually. I would like to talk about photobiomodulation and a recently conducted study in the US for the treatment of dry AMD. The name of the study is called LIGHTSITE III, and the results have been submitted to the FDA. But before coming to the details, I want to talk about the basics of photobiomodulation. What is photobiomodulation? Sometimes you can see the abbreviation PBM, is also known as low-level light therapy. It is an expanding medical technology in which exposure to low light is used to stimulate cellular functions, leading to clinical benefits. Photobiomodulation has been used for many decades in other sectors of medicine, like sports therapy, physiotherapy, surgery, dentistry, and dermatology. And if you Google it, you will find roughly 5,000 publications, and every month 30 new come. How is the situation in ophthalmology? If you go into PubMed, you will find roughly 30 scientific publications about photobiomodulation, where roughly 1,700 patients have been treated. Here you can see a synopsis of all the studies, and there hasn't been a single case reported about adverse or side effects. The same is also applicable for commercial sites where we have treated roughly 15,000 patients, and there is not a single case which has been reported about side or adverse effects. Now, how does photobiomodulation work? Photobiomodulation uses low-level light to stimulate cell functions and optimize energy production and blood flow. The target is a mitochondrial enzyme called cyclochrome C oxidase. It is abbreviated in short CCO. Here you see a cartoon of this enzyme. It is the fourth element in the electronic respiratory chain just before energy is produced. We are using 3 different wavelengths: yellow light 590 nanometers, which inhibits VEGF expression and helps to remove cellular tissue, cellular deposits in the retina. We have also visible red light, 660 nanometers, which promotes oxygen binding, which is needed to produce energy. And we use invisible near-infrared, which has the wavelengths of 850 nanometers, which drive electrons along the pathway. Both of these stimulate metabolic activities to produce ATP, and it inhibits inflammation and cell death. The target of photobiomodulation in ophthalmology is to slow the progression of degenerative eye diseases like dry AMD and to improve visual functions eventually. Now I want to that was the mechanism of action. And here you see the device which is used for photobiomodulation. It is called VALEDA light delivery system. It has been designed that it would fit optimally into a clinic or office environment. You see here how it looks like. The treatment can be delegated to the staff, to a trained nurse or technician, and the treatment per eye takes less than 5 minutes. No pupil dilation is required. 9 flexible treatment sessions are delivered over 3 to 4 weeks, and currently 2 to 3 treatment cycles per year are needed. That means the treatment cycle is repeated every 4 to 6 months. Now, let's come to the results of the LIGHTSITE III US pivotal study. The LIGHTSITE III study is an FDA IDE approved, double-masked, randomized, sham-controlled, parallel group multicenter study to assess the safety and efficacy of photobiomodulations in subjects with dry AMD. I will now present the 24 months data. Let's go first to the protocol recap. The BCVA pre-op was between 2030 and 2100. In the case of intermediate drusen and or geographical atrophy, it was confirmed by the masked imaging center, that was Duke Eye Center. Wet AMD patients were excluded, and patients with geographical atrophy in the central 1 millimeter. The primary endpoint was the change in BCVA from baseline at month 13 and at month 24. The sites performed additionally, among others, OCT, fundus autofluorescence, and color fundus examination. About the patient population, 100 subjects were included and 148 eyes. The time from diagnosis to treatment was 4.9 years. That means mainly early to intermediate stage patients, and the BCVA baseline was 70.6 letter score. Here on this slide, you can see the 10 sites which participated in the study. The medical monitor was Professor Dr. Diana Du from Stanford University. Here you see the study design. 6 cycles of treatment were done over 24 months. And the treatment cycle was repeated every 4 months. The randomization was 2 to 1. That means that means photobiomodulation versus sham. It was 2 to 1. And sham means sort of placebo. The patient was seeing a light, but the energy was reduced by 50 or 90%. Let's go to the final data set. Top-line data showed a statistically significant difference between the photobiomodulation group, which is here on top, the green, and the sham group, which is at the bottom, the dotted gray line, at month 13 and at month 24. The p-value at month 24 was 0.015. With this, the primary endpoints were clearly met. And after 24 months, the sham patient had an increase in BCVA on average by 5.9 letters, as you can see here in the green line. Now let's look which patients were winning and who did not win. Here you can see that 75% of all patients could improve their BCVA. 25% of the patients could not improve their BCVA, but this number was double in the sham group. It was 50%. Here you see the BCVA letter gain distribution at month 24. 58% of all photobiomodulation eyes responded with a minimum letter gain of 5 letters. 18.7 responded with a minimum gain of 10 letters. And even 5.5% of the PBM eyes could gain minimum 5 letters. Now let's look at the change in central drusen volume. change from baseline. And here we can see a non-significant minimal increase in central drusen volume with the sham and photobiomodulation group, but the increase was 4 times higher in the sham group. Here, let's look at some interesting OCTs. Here you have a case of macular drusen reduction following photobiomodulation. The patient was gaining 5 letters in the BCVA. Here in top you have the pre-op OCT, and at the bottom you have the OCT after 24 months. And the B scan, you see a considerable reduction in drusen volume, and in the thickness map you can see it was pre-op 84 and post-op 17. Here you have a case of macular drusen increase following sham treatment. The patient lost 3 letters in the BCVA and turned red after 16 months. Here you see the pre-op OCT on top, and on bottom the post-op, and you can see in the B scan a considerable increase in macular drusen. The drusen thickness increased from 15 to 47 microns. Now let's look at incomplete retinal pigment epithelial and outer retinal atrophy, in short iRORA. These are small pockets of geographical atrophy in the periphery. When the ring is not complete, it's called iRORA, and when the ring is complete, it's called cRORA, complete RPE and outer retinal atrophy. And let's look how it developed. Here you see the conversion to iRORA in eyes where iRORA was not present at baseline. At 24 months, it was 21% in the sham group and 13% in the PBM group. Now let's look at the conversion to geographical atrophy or cRORA with iRORA present at screening. The numbers are limited, but still interesting. In the sham group, it was 80%, whereas it was 20% only in the PBM group. Now, this is the most important slide where I would kindly ask for your attention. Let's look at the development of new GA after the treatment. The occurrence of new geographical atrophy was significantly higher in the sham group than in the PBM group. You can see here in the sham group, it was 24%, whereas in the PBM group, it was only 6% after 24 months. So the new onset of GA was 4 times higher in the sham group than in the PBM group. Here you see the adverse events. It shows very stable and safe profiles here. Now let's come to the summary of LIGHTSITE III. LIGHTSITE III met the predetermined primary endpoint in terms of change in BCVA, with a statistically significant difference between PBM versus sham treatment groups, whereby the p-value was 0.015 at month 24. On average, there was an increase of 5.9 letters increase in the PBM eyes. More patients lost BCVA letter scores in the sham group than in the PBM. It was 25 versus 50%. There was a non-significant minimal increase in central drusen volume in the sham and PBM group, whereas the increase was 4 times higher in the sham group, and photobiomodulation treatment with VALEDA shows excellent safety profile. The occurrence of new GA was 24% in the sham group versus 6.8 in the photobiomodulation eyes groups. Now, these results of LIGHTSITE III are similar to our previous studies which we have conducted, and this study has been accepted for publication in Retina, and in yellow you can see the reference, and it is already available on the online version. Finally, I would like to mention that these results have been submitted for the FDA for approval, whereby we are still waiting for feedback from the FDA. And this study has been supported with a study grant from the National Eye Institute. And I'm very happy to tell you that we will continue to treat and monitor these patients for another year.